Good afternoon, everyone. So glad that you could be with us today. I'm Nancy Myers from the American Hospital Association, and I have the pleasure of introducing you to the folks that you'll be spending some time with over the next hour. I know that all of us who work in population health and community health across the country are working to meet the increasing needs of individuals facing a wide variety of behavioral health challenges. And it's no secret that we're short over 250,000 or so of mental health professionals in the United States. So we clearly have to look for different types of solutions. Now more than ever, our hospitals and health systems can play an essential role in changing the behavioral health paradigm to one that is proactive, data-driven, evidence-informed, and population-based. With that in mind, we're excited at AHA to introduce a new collaboration with CredibleMind, an organization that we've worked with over the last several years and has spent the last 6 years introducing a population behavioral health tool to over 200 communities with a platform that makes it possible to scale their solution. That platform is now available to our members, and we're eager to collaborate in creating a learning community around it. So I'm excited to turn the podium over and introduce you to Dr. Derek Van Brunt, who's clinical professor of public health at UC Berkeley and the co-founder and CEO of CredibleMind. Derek, I'll turn it to you.
Nancy, thank you very much. I appreciate that. And hi, everyone. I'm glad to be with you today. I'm excited about our topic, which basically is population mental health. We all know what population health is, but we need to start understanding what population mental health is and that it's part of that continuum. And I'm also equally excited about the speakers that we have to join us today. We have 4 people teed up for us. Tucker Christensen is with Intermountain Health, a really innovative health system around the Rocky Mountains, and he's in charge of product management, digital services. Essentially, he's in charge of like the patient portal. We have Shamar Clements, who's a colleague of mine at CredibleMind. She's in charge of research and some other things at CredibleMind. I'm Derek Van Brunt. And then Debbie Zwerner is in Kentucky. She's at Owensboro Health. And she actually, we don't think is going to be on the call with us today, but we have her slides and I'm going to speak to it briefly as a case study of some of the work they're doing in the community. So let's just launch right in. And Nancy mentioned there's this collaboration that we have with the AHA and ACHI. And the idea here is it's really time to build awareness around both the need and the challenges that we have around mental and behavioral health, being mental health, and then add in substance misuse. I'll use those terms a bit interchangeably. And when you burn this down, the question becomes, what can we do better, both inside and outside the walls of care delivery, to improve the mental well-being of the communities that we serve? And kind of giving you the punchline up front, we need to start leveraging self-care in our communities and improve triage to help address this large provider shortage that we have in the area of mental health and be data-driven in that process. So here's what we're going to cover today. We kind of have this broken into 4 parts. First, very briefly, Shamar and I are going to talk about what we'll call the State of the Union, and that's how is the United States doing right now with respect to mental health? And then what's been the community health response? What are AHA members and their partners at the community level doing today that's working, that's measurable to improve the mental health of their service areas and the broader communities they serve? And what can we learn about what some of the thought leaders down at the community level are doing? Because we're starting, now that we've reached some scale in this program, we're starting to see what some folks are doing that are very effective to do things like drive engagement, collect data, get insights, and measure positive outcomes. And then finally, for those of you that may not be familiar with this community health program, we have 1 or 2 slides at the end that just give you some next steps if this is something that you want to learn more about. So that's how we are breaking up our time. And again, I would say this topic is all part of a movement towards population mental health. Today, our mental health system of care is largely a reactive system of care. We wait, on average, for people to have enough pain and suffering that they seek professional services, whether that's typically therapy or medication. Average delay average wait time for people with initial symptoms of anxiety and depression to when they actually get care is around 8 to 10 years. There's a lot that we can do in that interim to change the trajectory and the progression of these conditions. Again, punchline up front, early intervention works. And we're going to show you some of the data around that. So let's just jump into this snapshot of how we're doing across the country. And many people have heard, this is not a new statistic, for last decade, we've been talking about how roughly 50% of the population, of the adult population in the United States, has a diagnosable mental health condition in their lifetime. About 20% any given year. That 20% has shifted up. It's crept up a little bit in recent years. The pandemic certainly exacerbated mental health issues. There are many other factors as well, but that's still staying stubbornly high and getting a little worse. About a quarter of adults that have frequent mental health challenges lack access to care, both due to cost, which is this statistic, and also because they live in the equivalent of a food desert, but it's a mental health desert. We're going to talk a little bit more about that. And I'll just say up front, our youth is being disproportionately affected. And just over the last year, around 20% say they've experienced a major depressive episode. And as Nancy mentioned, we're about 250,000 professional behavioral health therapists short. Not to be dramatic, but we can't clinically treat our way out of this problem. That's part of the solution, is improving the quality and efficiencies of the professional services that we provide. But we need to start working upstream. And fortunately, we have tools that are operating at scale and that are doing just that. And that's what we're going to learn about. Let's drill into this sort of mental health and unpack that. Of these mental health challenges that people are reporting, and this is an NIH large poll over the last year, anxiety, as you can see, is disproportionately the highest area of concern that's reported, followed by depression and PTSD, and you can see the others on the right-hand side. But if we take anxiety and open that up, if you look to the left, you'll see what some of the contributing factors are: current events, the economy, the election, that's when this was being taken, and gun violence are big drivers for so many of us in the country. People are saying that stress and sleep are having a huge impact on their mental health. And as I mentioned, we have this workforce shortage, and it's not equally distributed around the country. So we have these behavioral health zones, shortage areas, kind of like a food desert. It's a behavioral health professional desert, and it's about a third of our country live in these deserts. So even when people may find the courage and may find the money and may find the transportation to actually go seek care, and those are a lot of barriers there, sometimes they just can't get it. I'm going to ask my colleague Shamar to take us a little bit into some of the additional statistics on these elevated rates that we're in and who's being affected. Shamar?
Thanks. As you can see with this Gallup chart, rates of depression have always been on a steady incline. This is showing rates that are based off of people being asked if they've ever been told by a doctor or nurse if they have depression or if they're currently in treatment. There's a lot of movement and an uptick in the slope of increase around the pandemic 2020, 2021, but there still continues to be a higher grade of elevation since then. What's not shown here is CDC data that demonstrated that when people are asked about their symptomology for things like depression, anxiety, feelings of hopelessness, feeling of constant worry, those levels stay about equal. That those the lines on those charts are pretty level. They did go up during 2020, 2021, but then came back down. So what we can infer from that is that while it's a lifetime common experience to have mental distress, there is an increase in help-seeking behavior. And so that may be due to a variety of things like increased psychoeducation, increased normalization, decrease in stigma, also like some of the minimization of barriers that came with telehealth and opening up things like digital apps and platforms such as CredibleMind. But with that, people are still, again, not able to access the support that they need because there continues to be a dearth of access to providers. And so across the board, people are struggling, but there are some particular disparities for certain demographics. On the left, we'll look at a chart that just shows in the dark blue people who rank their mental health or emotional well-being as excellent, very good, or good, and in the green as only fair or poor. Down the line, we can see that younger populations, people with lower income, people with LGBTQ plus identities, and people who rank their physical health as only fair or poor are demonstrating the highest levels of mental health distress and illness. Some of the things that aren't shown here are some of the racial disparities. And so just thinking about the communities that you're serving and your hospitals are in, the data across various studies shows that Asian and Latine people and men in general across races are least likely to get treatment. But also Black and Latine people in America have the most rapidly increasing rates of emotional distress. So when we think about treatment and help seeking, on the right, we have a chart that shows some of the barriers across different age groups that people are finding in order to get that care. As we've already mentioned, the highest and the most ranked barrier across all age groups is cost, affordability. People are having a hard time being able to find the funds and resources to pay for the cost of mental health care. But beyond that, people are also listing things such as difficulty finding providers, feeling like treatment won't help or that they can manage without any type of treatment or support, and still that shame or stigma, embarrassment that many people still have around seeking mental health support.
Shamar, thank you. Another factor here for all of us to keep in mind, especially as many of us are entering more value-based kinds of contracts, are the costs involved here around mental and behavioral health. If somebody has a behavioral health issue, there are costs associated with that. When they have a physical health issue, there are costs associated with that. When there's the comorbidity of both, costs go up generally 3 to 7 times. Readmission rates go up about double. And so this directly impacts the quality of outcomes and the costs of providing care. When we talk about behavioral health, it's not an isolated thing. We have to be thinking about whole person care, both from the standpoint of quality of provision of services, but directly affecting the performance against our value-based contracts. So what's been the sort of community response? What's happening at the local level? These statistics are not new. They've been stubbornly high for a while. And fortunately, there have been some interesting innovations and some really innovative people working at the local level. And we're just excited to share with you some of the stories of what's taking place. So first, let's level set with what is the community response. So as Nancy mentioned earlier, there is a digital platform. We'll call it the CredibleMind Community Mental Health System. And it is deployed in at least one area in all the green colored states today, covering over 40 million lives. So people that have access in those communities or organizations that have launched them in those states, representing over 200 communities, getting close to 500,000 community members that are engaged, closing in on 3 million minutes of time, average usage on this digital platform when it's launched in a community so each user is around 5 minutes, which is very high. So it's not like people are just using this briefly and going away. And you can see here just a timeline of this platform was initially deployed in 22, but it really started taking off in 24 last year. So last year is when we can see the users and the traffic increasing dramatically, which means we're learning a lot more and starting to learn more about the outcomes. What are people doing on this platform? They're learning around their mental health. This is about a mental health self-care system for everyone in a community. And there are a variety of different kinds of topics. There are over 100 topics covered on the platform. And it's essentially, you can think of it as an evidence-based one-stop shop for all mental health topics. And so a lot of the clinically oriented topics that you would expect to see are here, like depression and anxiety, stress, burnout, ADHD, PTSD, et cetera. But there are a lot of other topics here that are very interesting that people are interested in, like meditation, or dealing with loneliness, or caregiving, or flourishing, how to just be happier in their lives. So these are just some of the sample and more popular topics, but there are over 100 topics that people are really spending time on, trying to help themselves, or often it's on behalf of a family member or someone who they care about. Who's using this platform? Predominantly women across all ages, and people are using the system or accessing it principally through mobile. So that has to do, as you'll see in a minute, when communities launch these sites, there are community engagement programs, and people learn about them when they're out and about, if you will, in their community. And so they're usually using their phones to come in. They're not really learning about it necessarily when they're sitting at home. So what is this platform? I'm gonna give you folks a little 2-minute tour on a couple of screenshots of what this platform is, but let's define it first. So it's the CredibleMind solution for AHA members and their partners, which is a website essentially that can be localized for your community, your service area. It could be a city, a county, a region, could be deployed for a whole state. So for example, this is launched throughout the state of South Carolina right now. And once it's launched, it's available to everyone in that community, and there's no charge associated with their utilization. There's just the initial sort of setup and licensing of the system, but the users, it's all open access. And what the users get is evidence-based self-care and triage where they can find services. I'll show you some screenshots in a moment. But for you folks that end up sponsoring this, there are a couple of really important things that you get. One is analytics and reporting. So as tens of thousands of people in your community are using this sort of mental health, behavioral health platform, you're able to see the kinds of topics that they're looking at, what they're worried about, where there are higher risks, if you will, in terms of subject areas or geographic locations in a region. And this can create insights. And I'll show you some example of what those reports look like. And then there's also best practice sharing. We are not in this alone. And as I mentioned earlier, there is such innovative work going on how to create awareness and engagement at super low cost, obviously, in a community. And then what are some of the interventions that then people put into place? So one way to think about this, if you step back, this is a bit theoretical, is population mental health is putting these two things together. It's so that any person in a geographic community, one, knows about the professional services that are available, that's depicted on the right, but two, that they understand where they can find science-based self-help. And that's the box on the left. And the reason you see those percentages on there is that it turns out, we were surprised to find this years ago when we were doing research, that of people with mental distress, 3 out of 4 approximately really are just looking for what they can do on their own or to help a friend or family member. They're not looking for professional services. Now, I want to pause on this point because this is critical. If 3 out of 4 of the people in the communities that you serve aren't looking for professional services, but we're not giving them evidence-based self-care, then they're going to go look for professional services. And we already talked about how we're 250,000 behavioral health therapists short. So we're clogging our own system. So what this does is it's a natural triage mechanism and to help people find what they're actually looking for, which is self-care 3 out of 4 of the times. And then for the 25%, let's actually help them find services. So what does this look like? Again, this is a digital platform, which is a fancy word for saying it's a website. And there are 2 basic products on here. The main one that almost all the communities that I've mentioned so far are using is called self-care. And there's another piece called Smart Screen, which I'll show you very briefly. So self-care, as it sounds, there's a front page. This can sit inside of a page that you may already have. So let's say that your community health department is working in a coalition and there's already a healthy living or well-being site for a community. You can take everything I'm going to talk about and just drop it inside that other site. But if there isn't such a site, this can be the front door. Most people make this the front door because it's pretty powerful. And it gets branded for your local community. So that could be the name of your hospital. It could be the name of a coalition, depends how you're working. And all the things on the homepage, the color schemes where you see on the upper right, anxiety, stress, addiction, these are like drag and drop tools. So we'll configure this to look like what you want. And there are all kinds of things you can do here. There are about 15 features. I'm going to just show you 2 very quickly. One is there are topics, right? These over 100 topics like anxiety, stress, depression. And if you click on something like anxiety, you get a page that looks like this. And I will call your attention to the fact that there's very little text here. With all these hundreds of thousands of users that we've had on the platform, as soon as you put a lot of text, they're gone. That's not what people want today. So they do want to know that they're not alone and there are things they can do that can work. But as you'll see in a moment, what they can do here is click on the upper part here where it says what helps and find a summary of what science says you can do if you have anxiety. Before I click on that, I just want to point out that this general page of anxiety, this brings up local resources in your community. There are many places throughout here. I won't call it out as we go through this quick 2-minute sort of demonstration, but we'll link to local resources, whether that's provider groups, 211 kinds of resources, etc. And this is a screenshot actually out of Owensboro. We're going to hear about Debbie Zwerner's case study in just a moment, but this is the behavioral health group that they work with. And so if people are looking up anxiety on their platform, they want those people to see and learn about River Valley Behavioral Health Services. Your site, obviously it would look different. Okay, so let's say we clicked into what can I do to help. Here's a list of 17 things that you can do to reduce symptoms of anxiety. And guess what? No surprise, therapy and medication are some of the things, and you might want to click in and learn more about those. A lot of people have some concern or stigma around therapy or medication, so you can learn about that before you go seek it. But there are all these other things, and I have in my family a member who's had anxiety, has had medication and therapy. We use this system for my family member and learned 2 things off of this list. One, how important sleep is to reduce symptoms of anxiety. And 2, that music, creative expression here. These are the areas that we clicked into. And if you were to click, for example, on sleep, there's a whole page on how sleep helps reduce symptoms of anxiety. And then I skipped the screenshot here, but I jumped forward to, I could then ask to get a list of some of the preferred apps that are available. And then I now have an app to help me sleep, if that's what I wanted. Maybe it was a podcast, maybe it was a video. This system has over 20,000 resources that have all been vetted by a clinical team so that each person, based on whatever evidence-based approach they're looking for, to help them with a certain issue that we then tee up high quality resources to help them take positive action. At the end of the day, this is a positive behavioral health change model. And so I'll just close that family member comment with that was 3 years ago. And this family member now plays about a half-hour a day of guitar, has an app to help them sleep, no more medication, no more therapy. That stopped 3 years ago. They feel much better. So that's evidence-based self-care, and that's what we need to make available to everyone in the community. And by the way, interestingly enough, and I'm not slighting any of the professionals that they worked with, but their physician and their therapist weren't telling them about these, not just the resources, but the evidence-based approaches that they might take. So this really complements the professional services that are being provided in the community. The other thing on this whole self-care platform is our assessments. This is a very popular feature. People love, as long as it doesn't take too long. You can see most of these only take 2, 3, 4 minutes. People love learning about how they're doing. Again, it could be for a child or a parent or a friend. And you just answer typically 5 to 10 questions, and you immediately get a report with your risk level. Do you have low, medium, or high risk? And we customize the reports again for you, your partners, and your community. So if you have people coming in and they're scoring high risk for depression, where would you send them? That's where we'll send them. But if they're low to medium risk, we're probably going to nudge them more towards self-care. So it optimizes the professional services for those that really need it. We're not hiding any services from anyone. As you'll see in a moment, we have statistics now on how people use this, and they naturally self-select to the right level of resources, which is very exciting. That's what we're all about here. This system's available in well over 20, 30 languages. I've heard it, there's several dozen that it can be made available in. So that can help address many access issues in the communities that you have. Very briefly, we want to tell you about a second. So that what I just showed you was evidence-based self-care. You launch the platform in a community. As you'll hear in a few minutes, we help drive awareness and engagement to the platform in your community. And I'll talk to you about the outcomes of that in a moment. There is a second capability that most communities, it's pretty new. So most communities haven't added it yet, but it's very powerful. And it emphasizes more the triage when people in the community are looking for care. If you're a larger community and it's complex, there are lots of different kinds of services based on insurance type, et cetera. Where do they find care? And so we're just going to take you through a couple of screenshots here. And Shamar, why don't I turn this over? This is like a short case study in Monterey County.
Yeah, I had the privilege of working with Monterey County, California to pilot our smart screen product. This came out of a problem that they were having, which many counties across the nation are experiencing with a growing demand for services without a growth in staff. So there's a large disparity of need, and their goal was to increase community awareness and access to the variety of mental health resources available locally, also to alleviate the burden on the clinical screening and triaging process, but also to just promote early detection and self-care amongst their community and specifically among underserved populations. One of those underserved populations is their Spanish-speaking community, which is very large in Monterey County. So we're just going to go through some screenshots of what the Smart Screen product looked like. On the homepage, there is a bilingual call to action introduction for people to start the screener. This is a fairly comprehensive screener, so it takes longer than some of the other ones that Derek mentioned. But people will go into the questions. It is a compilation of validated scales, but we can also include custom questions or referral rules that are specific to your geographic area, to your community, so that we can match people to the services that are available and are most needed, and also get that data and tracking of some of the condition areas and concerns that are most of concern in your community. So once someone goes through all of the questions, they get a comprehensive results of the areas that they're doing well or areas of greater concern. And again, you'll see that it goes across the variety of conditions that have validated scales that we can customize, add, subtract, really tailor to what's needed to the populations that you're serving. So you see the different categories of how a person is doing, well, poorly, etc. They'll get some psychoeducation and referrals to not only local resources and programs available in the area, but also to self-care, like the videos, the apps that are specifically tailored to the results level that they get. And in order to track those results, a person will see this information. There's a results code that allows them to access their results again after they've taken the assessment and the screener, but they can also use this to share with family members, friends, and any providers that they may be in connection to, so that those people can see their risk areas and providers specifically can see even the individual answers to questions. There's also quick links to things in the community based off of the results. So that may be something like the contracted substance use providers in the county, any front door emergency mental health locations, or even hotlines. And then there's just the information on how to access self-help and to share this code with others. And Derek will talk about some of the results that we saw after a year of implementation with our project in Monterey County.
Shamar, thank you. And the point is, people in the community can come in and go through that screener anonymously. And then at the end and get this little report. So it's very helpful. Some people don't look for care at that point. They're like, oh, my risk is low. I understand more about this. But some do want to go on for care. And with that results code, they can opt in to start sharing that information and kickstart the behavioral health intake process. So the bottom line is it can streamline the administration around behavioral health intake. And in Monterey County, they basically realized that they had too few providers. And at the same time, they felt that they were failing the community because they knew they wanted to reach more people, especially youth and especially people with higher acuity. And so they needed some kind of innovation like this to address that. And so UC Berkeley sent in a team and did a 1-year evaluation. So this is a third-party evaluation. And here are the results. And there's a whole report. So if you're interested, you just ask us for the Monterey report. And in their words, the county and partners say, one, they tripled access in the community, meaning total number of people in the community that knew about services and either got some kind of a support or information or applied or whatever, tripled from the year prior to when the system was put into place. They had excellent outreach to youth, Spanish speakers, and people at high risk. You can see the numbers there on the right. They were almost dumbfounded with how well it helped reach these folks. And then third, the costs for the overall county went down. And no one is actually certain exactly why it went down, but the prevailing theory is that people are spending so much time referring people. There's so much administrative work of people coming in saying, oh, you don't really need to apply here. You probably want the service over there. Or, okay, you want to apply here, fill out this paperwork. There was so much administration that went down and that they actually were able to spend a higher percentage of time on actually their clinical work. So these results are in. They're very powerful. But this is for mid to larger communities that have a more complex set of services. The population in Marin County is around 250,000, if I remember correctly. And that's probably about the right size community for this kind of more sophisticated system. Okay, so whether you're using self-care or the triage smart screen system, there's all of this data that gets collected anonymously. So this is aggregated, de-identified data of people in your service area, in your community. And what kinds of value could that have? It's tremendous. You can see over time how usage varies. You can see if you can benchmark. So how's your community look compared to other communities like you? So let's say you're a rural community. Do my levels of risk when people fill out those risk assessments? Do they look more or less the same as other rural communities, or do I stand out? So for example, this screenshot here would be a community where if I was the public health director, I'd be asking myself, or head of community health for a given service area, I'd be asking myself, what is going on with our youth here? Because we have disproportionately high risk youth around substance misuse compared to other rural communities. So communities that look kind of like us. And then that becomes this data-driven, informed process around getting community partners together and addressing issues like that. So let's go to another case study, which is Intermountain Health. And I want to turn this over to Tucker Christensen. And Tucker, so glad you're able to join us today.
Thank you, Derek. And hello, everyone. I'm excited here to talk a little bit about Intermountain Health and mental health and what we're seeing and doing in this space. So I'd like to start a little bit just explaining who Intermountain Health is, our mission, our size. Then I'll go into what we're seeing and then a few of the things that we're doing in this mental health space. So our mission across Intermountain Health is helping people live the healthiest lives possible. We also have a subset of entities that have a Catholic mission. And theirs is we reveal and foster God's healing love by improving the health of the people and communities we serve, especially those who are poor and vulnerable. So as I think about these missions, we are non-for-profit, and it's really all about serving the community and being proactive. I think, Derek, you mentioned earlier, we can't just be reactive here. We really need to be proactive. That's what Intermountain's all about. We're about being there for our communities, helping them stay healthy, helping them when they get sick through the whole journey, physical, mental, all of it. And really, we're doing that to achieve these missions. In terms of size, we cover 6 states in the Intermountain region: Utah, Nevada, Idaho, Colorado, Montana, and Wyoming. We are a fairly large healthcare system with 33 hospitals, 409 clinics, 4,800 employed physicians, and behavioral health is a large portion of that. 8 of our hospitals have dedicated behavioral health inpatient units. We've got 17 clinics that are dedicated to behavioral health, but another 449 that have behavioral health specialists integrated in those clinics, and almost 700 of our physicians and APPs and so on are focused on behavioral health as well. So what are we seeing? First off, I think it echoes a lot of what Derek and Shamar were sharing earlier. We are definitely seeing that growing demand of mental health support and growing awareness in this space, as well as a decline in the supply of providers. We're also seeing a varying severity of the conditions and needs. We see this, we have low condition severity, could be something as simple as I need help getting through a tough time, right? To very severe ongoing 24/7 monitoring and everything in between. The full spectrum we're seeing as a healthcare system. We're also seeing patient preference is a key part of this. A lot of people don't want to talk to doctors. A lot of people do. And so as we think about the solutions, it's not one size fits all. We need a comprehensive set of solutions that we can bring to our patients, and we need to help navigate what those solutions are and help them be able to pick and choose the right thing that's going to help them out based on the severity of their conditions as well as their preferences. In the Intermountain region, risk of death by suicide is also a top concern of ours. Across the 50 states, all 6 of our states are in the top 11 highest risk of death by suicide. And that's one of the key indicators around overall mental health. And so it's a particularly important area for Intermountain. And lastly, on the financial side of it, as we think about the traditional historical fee-for-service model, it's not sustainable in a lot of parts of healthcare. That's very true in behavioral health as well. It doesn't work for our health system. It doesn't work for our patients. And so we're moving more to the value-based care approach. And we've been doing a lot of that for a number of years. We call it in Intermountain, we actually call it proactive care is the term that we use around that. So this is about what we're seeing. Let's talk about what we're doing. So first off, this is not a comprehensive list, just a couple of highlights I wanted to call out today. Behavioral health is a key part of our overall proactive care strategy. We are looking at that holistic health, physical and mental. I think Derek's comments there earlier about how the costs go up and the severity of conditions go up and you have those comorbidities, very true. So behavioral health is a core part of our strategy. A couple of specific things we've done. We launched the CredibleMind platform in November 2024, so just over 6 months ago. It took us about 3 weeks to get that set up and going, so fairly rapid getting that in place. And we've seen over 12,000 sessions in our first 6 months. There's a pretty rapid adoption of the platform and reaction from our communities. What we're seeing there is about an 85% thumbs up rate on people saying that the content was helpful, useful, things along those lines. So I'd say great start here, kind of getting out there, getting the self-care platform going. In 2021, we introduced Connect Care Behavioral Health. So Connect Care is our 100% virtual telehealth part of Intermountain. They've, for well over a decade now, they've been doing urgent care. In 2021, we introduced behavioral health specialists. That's one of those 17 clinics that I mentioned previously. And they've been growing quite rapidly. In fact, in 2024, 15% of our net new behavioral health patients came through the Connect Care Behavioral Health Clinic. And that's particularly helpful, I think, for us because we have a lot of rural communities where it is not feasible or very inconvenient to be able to get out and physically visit a behavioral health specialist. Next, we introduced the behavioral health hotline in 2020 and virtual triage in 2022. So this was an initial response to COVID. At that time, there was a lot of anxiety and fears and clinics closing down or temporarily closing down. And do I go into my doctor for this or not? Like all sorts of things going on at that time. And so we introduced this hotline that anyone in our communities could call in, and we'd do some triage and help point them in the right direction of the type of care that they should get. We expanded that in 2022 with a virtual chatbot sort of experience where they could go through, chat with our bot and answer some questions. And based on that, we point them to the right sort of resources. We got about 23,500 sessions last year through these experiences that led to 4,500 appointments. So what I like about this is one's a sizable number of appointments, getting the right people in, but it's also helping triage, get the right people. The majority of these people, we didn't need to get into appointments, and we were able to send them to things like CredibleMind Self-Care to get the care that they needed. Lastly, I'll just close up here. There's a lot changing right now with technology. I'm fortunate I get to work in digital services, so it's all about consumer experiences and our community's experiences in digital. And with AI, things along those lines, it's an exciting time to be working in this space. I don't necessarily have anything to announce specifically in there, just that we're exploring it, we're looking at potential applications.
Tucker, thank you very much. And we expect to have some time for questions. So if you have questions for Tucker about what he was just laying out here, just drop those into the chat because we're going to use the chat as a place to grab questions that people have. As I mentioned, Debbie Zwerner, who's in charge of community health at Owensboro Health, a system in Kentucky, was not able to be with us today. I'm just going to give you a little less than 1 minute summary here, but this is a health system working with a regional behavioral health provider and others in a coalition. And really what they realized is they had a whole moniker of it's okay not to be okay. And they really wanted to get awareness in the community out there around it's okay to look for help around mental health. And so they grab these community partners and brought them together. Again, a lot of this kicked off around the pandemic. And they launched this awareness campaign to encourage people to seek care. They used a lot of innovative programs to attract attention, including putting QR codes around town where there would be like posters and other kinds of things where people could just find access. And it's working really well. Their latest kind of marketing, if you will, is around on the right-hand side there where it says, seeking help is a sign of strength, not weakness. And they've integrated this program with 988 and other partners. And so this has been a case study through, and a lot of their work was with the AHA through the Hospital Community Collaborative. So many of you may be familiar with that sort of network. And there's a case study. You can see the URL at the bottom, and all you have to do is just send us a note and we can send you the actual case study. But this is a nice concrete example of how they got tremendous engagement in the community, working with coalition partners. And the River Valley Behavioral Health is what's called a CCBHC. So one of the sort of higher, meeting a sort of higher threshold of provision of behavioral health services. And they're using this system, this self-care system, and the assessments to meet some of that criteria. So what are we learning? We've talked about how there is a tremendous demand in our communities around mental health, behavioral health, and that there's an opportunity to provide self-care to augment professional services and have this kind of rational, almost triage effect and let people go to the right level of care. But what's actually happening? So let us share with you some of the results, which are really exciting. So first off, these platforms, when they get launched, like Tucker said, I think he mentioned Intermountain's had a little over 12,000 sessions. We are getting a lot of utilization, and it's not just about clicks, right? A lot of marketing folks, different companies talk about clicks. That's what's important. Clicks are not what's important. At least we would say that. Meaningful use, people doing something that helped is what's useful. And so we track that. And about 2/3 of our users are doing something we call meaningful use, i.e., they took an assessment. And maybe they found out that they were low to medium risk for something that they were worried about. And they felt, you know what, that's not too bad. I can deal with that. I'll go find a resource or two and I'm good, and they go away. That was meaningful and productive. Or they downloaded an app to help them sleep on a regular basis better. That's a meaningful use. And that's not an outcome, but it's meaningful use. So 2/3 of people are basic. We can see what they're clicking on. Again, we don't look at individuals, but on an aggregated basis. And so that's very encouraging. We then looked at the data of all the utilization, and we looked at all kinds of things. Are there differences between urban and rural communities and suburban communities? Are there differences in utilization patterns of different affinity groups, et cetera? And surprisingly, for example, between urban and rural, we didn't find a lot of difference. Like anxiety and depression, both the amount of the risk assessment scores or how many times people clicked on different topics, they were pretty similar. Really, only two things jumped out that I will share with you. One is that we did find that the risks around burnout in urban communities were substantially higher, that on the left. And the other thing is on the right-hand side, where it says rural communities, we found a dramatic increase in the risk of substance misuse in rural communities, which is supported by NAMI's statistics around higher rates of suicidality in rural communities. So those are two of the insights that we can share with you from the data that we're looking at. There are others that we're finding. What do users say? Over 90% are saying, this was helpful. I liked it. It was useful. I'd tell a friend. About 70% say they understand their well-being better. That may sound like a soft number. It's not. If somebody feels that they understand their well-being, their sort of health status, if you will, better, their health outcomes are dramatically better. So that's actually really important. If you jump off to the right, that's the most encouraging sign from our perspective, is that over 50% of users responding to these online surveys when people are using the system are saying that they're making positive behavior changes. That is music to our ears. That's why we're all here, is to help people sleep better, get angry less, work better with others, etc. Feel less, more emotional regulation in response to PTSD, etc. If there was a most important statistic to share with you today, I think it's this one. And this is hot off the press. We just learned this in the last 30, 40 days. And that is, across hundreds of thousands of users that we have on our system, we are now seeing a clear pattern, which is people that come in and use these assessments. And remember, the assessments are a very popular feature. Those that screen at low to moderate risk are over 80% more likely to go into self-care resources. Now, if you think about it, that's exactly what we want. We want people with lower risk to try and help themselves first, or a parent or a friend. And then if you look over on the right, those that score at higher risk and probably do need professional services are over 30% more likely to actually pursue and seek clinical resources. So that is the perfect storm, if you will, around, it's almost like a natural selection of triage in the community. So going back to Monterey County, why did we do this big innovation project with Monterey? Their behavioral health teams felt overworked, and yet they knew they were underserving the community. They tripled access in the community, but they weren't any more overworked. Why? Because of this is the impact that we want. So when you launch this platform into a community, there's this tremendous opportunity to, one, drive awareness, but then two, start getting this effect of helping people find the right level of resources. And we haven't gone into all the details here, but it's not just self-care or clinical. There's self-care, there's peer support, there's coaching, there's online therapy, bricks and mortar therapy. All of that gets, if we work with you folks, we make sure that all of those things are being layered in ways that you want. So what are we finding that these local players, right? So community health departments and their partners at the local level, what are they doing to drive engagement and to get these positive outcomes? And we looked at over 20 attributes of these over 200 communities that have launched this system and we found that there were 5 attributes that highly correlated with lots of traffic and awareness. And these are the 5. So one, that they don't work alone. So if you're the community health, if you're the AHA member and you're the community health department, really good idea. You're probably already working with a coalition, but if you're not and there's one to work with, really a good idea to do that. That almost always works to integrate better into the community. Having a strong champion, putting someone in charge of improving the mental well-being of the community, leveraging local digital advertising. These are things like Google Ads and others that can be geo-targeted, very inexpensive, drive wonderful awareness. Tap into multiple channels. So it's not just community health and United Way and YMCA and the health department and a few others. It's getting law enforcement involved, schools involved. And so we have a whole checklist of players and what the value proposition is to them. When you tap into those channels, you really get the word out. And then finally, keeping the message fresh. We provide content every month so that, actually a couple times a month, so that whether you want to post to social media or send out newsletters, all that stuff, you've got all the material, just click some buttons and you're able to send that into the community, which again drives a lot of interest and awareness. So what kind of traffic are these communities getting? We've been stunned at how high it is. If you launch in a geographic region, let's say you have 100,000 people in the service area that you serve, 100,000, that's your target population. If you're in the worst quartile performers of the 200 communities that we're working with, you would have 4,000 people using the system. And if you're in the upper quartile, you'd have 12,000 people using the system. This data was collected over an 18-month period. So take a third away if you want to think of that as an annual number. So basically, you can get about 5 to 10% of your entire geographic population using this system. That's your opportunity in terms of impact at scale in the community. And we're frankly just getting better at this as we learn more and more. And I won't go into it, but these are just examples all around the country, in Indiana and Nebraska and South Carolina and Connecticut, of all the different ways that people are working. I'll mention 2 that I find particularly interesting. One is in schools, like high schools, when students are getting their ID cards, they get a little QR code, like this thing over here on the lower right. And it's on the back of their ID. And the QR code, if they click, basically zoom on it, it takes them right to a page that helps with youth mental health issues, right? Topics like cutting and bullying and things like that. And then law enforcement is using the system. The sheriff's department or police, when they go out to someone's home and there's some interaction, which often can be rather traumatic, they leave behind cards and things that say, we really care about you and here are resources to help you through these issues. We've even had one sheriff's department tell us it's their favorite part of the day is being able to tell people, not just enforcing the law, which they need to do, but to actually help people with the aftermath of that. And I'll tell one more, which is 988. Obviously, we're all familiar with this, and it's a wonderful program, and it's principally around urgent need and crisis need, but there's a follow-up component to 988. So programs are incorporating this self-care platform as a tool so that after the initial crisis, here are additional materials to help you and the family through those issues. So these are just some examples, case studies of what's going on. I'm going to just have 1 or 2 slides here to give you a sense of, as you're sitting there, if you're not part of this community, we think of these 200 communities out there in the country as a community of practice. We're learning together. We didn't make up the ideas around QR codes on student IDs or sheriff's department using our system. These are communities being innovative, and we are learning. And what we're trying to do is act as a hub of best practice sharing about what's going on, because it's accelerating. So let me just explain how you can get involved if you're interested, and then we're going to open this up to questions in just a moment. 4 things to keep in mind. 1, if you're interested in going down this road, think of the partners that you might want to pull in. So, if you're the community health department in a hospital or health system, you may want to pull in a local behavioral health player or the public health group, United Way, YMCA, et cetera, law enforcement. And we will customize this for your community. So don't worry about it in terms of it'll be branded how you want. We'll tie in local resources. We can make sure it's available in languages that are important for the different populations that you serve, et cetera. We'll obviously help you with benchmarking so that we'll help you. We collect all this aggregated data and we give you formatted reports so that you can see, quote unquote, the insights. But we also, if you're more sophisticated, can give you data feeds, which you can dump a lot of this aggregated data into analytics programs like Tableau and other things if you want to mesh this up with other data that you've got going on in the community. And I, as Tucker mentioned earlier, our average launch is 2 to 4 weeks. When organizations want to do this, it doesn't take long to actually get this moving in your community. There's a QR code here, and there's also an email address. So if you want to learn more, email Scott or just hit this QR code. Any of those will get you to us if you want a copy of that Monterey report. If you're interested in getting a demonstration, maybe you want to pull in some of your colleagues, we're really happy to do all of that with you. Okay, that concludes the formal part of our presentation. So let's open this up to questions. Ashley, let me turn that over to you.
So the first one, what are the methods used to refer patients to this platform? PCP, referrals, social work, community interactions, etc., or is it just placed in the community?
All of the above.
Okay. Could the presenter speak a bit more to pediatric focused or pediatric inclusive efforts?
This system is really optimized for people age 15 and above. There is content that is there that's relevant for people younger than 15, videos that helps a younger person understand what it is to have ADHD, but that should all be mediated through a counselor or a parent. So that's a deeper discussion.
With respect to more women accessing the system, are you able to track if they are seeking services for themselves or a family member? And if a family member, can they say who it is, husband, father, brother, son, etc.?
We do have some information on that, but I don't have a bottom line. And that's a very astute question because there is no question that women are looking on behalf of family members.
Where are the resources pulled from? Does the sponsor input them or are they automatically plugged in?
Both. So we provide a whole database of over 20,000 resources, of which some can be suppressed if you want to suppress some. You can add topics, you can suppress topics. Most people don't, but you can. And these have been vetted. But in addition, your organization may have some favorites, right? It's, oh, we've got a list of some resources we really like, whether those are local resources like organizations that provide services or whether they're apps and videos. All of that gets layered into the system and can be prioritized in the user interface when someone does a search.
I'll use this as our last question, but someone asked, what is the cost model to bring this to a community?
It basically is, it's tied to population. I'm going to throw out a number, but it's really not very expensive. The self-care platform, that's the main platform that we talked about, is like maybe 10 to 25,000 a year, depending on the size of your community. That would be a 50,000 population, maybe up to 500,000. If you're 5 million people or something like that, if you're LA County, we probably need, it's a different set of numbers, but it's generally 15, 20K plus or minus a little bit a year. Tucker, did you have any final thoughts?
I just add, Derek, I think the self-care is a critical part of the strategy in the program. We've done a lot of research, talking with patients, various surveys, things along those lines, and not just looking in the mental health space, but looking across like a whole variety of different digital health needs. And the one that's bubbled to the top as most in demand, or one of the top in demand, has been in the mental health space. It's just a critical area, a key part of care.
There were 2 specific questions. Is ACHI-CredibleMind available to Intermountain clients in Colorado?
Yes, it is. Yes, it's across all of our communities. It's intermountainhealth.crediblemine.com. So if you're in any of those 6 states, you've got access to it. You can go hit that website.
Perfect. Someone else asked if it was available in Northern California, Humboldt County.
Not to my knowledge.
And then I would say this will be our last question since we are over on time. Are there any examples or knowledge of this platform being used in the emergency recovery context?
No, I would say the closest thing is like a 988 where there's the initial crisis and then there's the follow-up to the crisis where this is being used. But I will say this, that when people come, sometimes people come into the system, especially the triage system, Smart Screen, and they may be in crisis and the system picks that up. So when people are answering questions that indicate crisis, immediately there's logic that will respond to that and direct them accordingly to 988 or other resources as appropriate. We'll close here with two thoughts. I mentioned information. There's a QR code here, and there's also an email address. So if you want to learn more, email Scott or just hit this QR code. And a big thank you to AHA and ACHI for basically conducting this and giving us helping create the awareness for everyone. Okay, everyone. Thank you for joining. Thanks, Shamar. Thanks, Tucker, for joining us. Bye now,
Thank you.
Nancy.